Thank you all. It's a real pleasure and honor to be here. And if I'm not my usual energetic self, it's because I haven't had too much sleep. It's so awesome to see many familiar faces here and speak to you about this topic that's very dear to my heart, about diagnosing individuals with ataxia and seeing them as a neurologist who has now practiced seeing patients with ataxia for about 15 years. What I want to start out by saying is that the journey of a patient with ataxia is very individual. In this era of kind of cookie-cutter neurology where you have checkboxes for these are the outcomes, that just doesn't apply to the ataxias. And I want to narrate this with some patient stories of individuals I've seen, and some of them, or at least one of them, in their own words. So this is my disclaimer. I don't have anything that's relevant to this talk today. So I'm going to start out with a patient that I saw now in 2009 when I was a movement disorders fellow at the University of Michigan. She was a 70-year-old who'd had 2 months of balance problems, severe speech problems, and was unable to walk the prior week. This was so debilitating that when she came into the hospital, she was unable to walk at all. And this is how she sounded.
All right, go ahead and get some.
Good days, wet and breezy, and upper.
Perfect.
This was, as you probably have realized, she has very prominent dysarthria, speech changes, and which made it very hard for her to communicate. And she was unable to walk, and she has the characteristic abnormalities in movements of these ballistic movements,
If you want to start.
which shown here, and her daughter is
Now touch
holding
your
up her
nose.
hand,
Finger.
and
Good.
she misses
Good. Now do it with your left
reaching the
hand.
target several
all
times,
right, hand.
which many of you already know is characteristic of ataxia. In her case, I think the diagnosis was pretty obvious, but I have had a number of patients over the last decade where at the outset, symptoms are mild enough that patients often know what they have, but their provider has no idea what they have, which I think is an important limitation and shortcoming of our ability to diagnose early and manage patients with ataxia. What I want to highlight with this story is the relationship between a patient and their physician, particularly for ataxia, spans decades. So this patient, whose name I'm going to withhold for reasons of privacy, was diagnosed with what's called a perineoplastic ataxia. So the causes for ataxia can be very diverse. And I think the expectation and the initial visit really should identify potentially treatable causes of ataxia that can be identified early and with intervention at least moderate the course. In her case, what she had was an underlying cancer that was only apparent 3 years later. So I continued to see her over the years, and her cancer was treated, and she was actually in remission, and she passed away last year from a heart attack at age 82. Although she had significant disability from her ataxia, at least the underlying cause was addressed, and her life-threatening malignancy was treated. So I think it's important to expect that you will have answers for what your ataxia is, and it's going to be a very individual answer. So there are so many diverse causes for ataxia, and it's important to recognize that each patient's ataxia needs to be individually diagnosed and treated. And therefore, getting a diagnosis of ataxia really depends on how acute the presentation is. In In the case of the patient that I just showed you, her acuity was very rapid, and it was important to recognize things like autoimmune disease as the cause for the ataxia. As many of you in the audience know, it also depends on your personal experience with ataxia. For example, a family history. So individuals with a family history of ataxia have different expectations going in, and in some ways, a lot more anxiety-provoking because they have a crystal ball to see what their future may be from family members who have ataxia. And I think recognition of the clinician as to what the ataxia type they have in the family is paramount in order to both provide reassurance, but also understand what's going on in you. So I think I'm going to make a plug for an initiative that the Ataxia Foundation rolled out, which is the Ataxia Center of Excellence. I think it does make sense to seek expertise in ataxia care because recognition and identification of what the symptoms are and whether they are truly related to cerebellar impairment and are truly ataxia is not uniform among providers. So there are, I still hear from patients saying that their provider, their primary neurologist, they're the very first patient that they've ever seen with ataxia. And this is an important shortcoming. And even providers who have been trained in movement disorders often have no training in seeing or treating individuals with ataxia. And I think the other initiative that the Ataxia Foundation's started since several years ago, the ACT, the Ataxia Clinical Training Program, is an attempt to remedy this. So I think it's important to expect to not just get a diagnosis, but really know what the cause is. And the causes are very diverse. They may be toxic, they may be metabolic, they may be nutritional, or they may be genetic, or they may be sporadic degenerative conditions. And it's important to know what it is. I think, again, to reiterate this, I think I've been so honored to follow individuals with ataxia who I have learned as much from as they have hopefully been assisted by me. I'm going to kind of summarize the individual that I just showed you. So she was only diagnosed with her cause for ataxia 2 years later. So sometimes an immediate answer is not apparent. So she had an underlying cancer that was only diagnosed 2 years later, and that was therefore diagnosed with a paraneoplastic ataxia. And she died at age 84 with her really loving daughter who still misses her greatly, helping with her care. And I'm very grateful to the family for letting me show these videos because patients like her mean so much to me to help me both understand and motivate me to do more, to try and find treatment for individuals with ataxia. I'm going to tell you a couple of other narratives from patients. A 35-year-old woman who had several years of gait changes was diagnosed with multiple sclerosis and was going to and this is an exciting time for things like multiple sclerosis, where we have very potent immunosuppression that can potentially attenuate the course and improve symptoms in multiple sclerosis. So she was diagnosed with multiple sclerosis and was suggested a potent immunosuppressant to try and treat symptoms. She didn't have a family history, and based on her evaluation, she was actually diagnosed with a genetic cause of ataxia known as RSACs. And I'm only bringing up this specific form of ataxia because when you talk about an individual genetic form of ataxia, it's thought to be rare, that there are very few patients. And many of you have probably heard from your providers, there's only 12 other individuals worldwide with what you have. But I think it's important to recognize that if you don't look, you don't find it. And we are recognizing that there are increasingly more genetic forms of ataxia, and causes for ataxia that were thought to be so-called sporadic are all now increasingly of a genetic cause, even when there's no family history, and that's important to recognize. So this uncommon form of ataxia, known as the autosomal recessive spastic ataxia of Charles-Voisin-Saguenay, was thought to be isolated to a small region in Quebec, but we know now that this is present worldwide and can present later in life, similar to this patient. So importance of identifying what the underlying cause is it avoids needless and potentially harmful treatment that is not going to be helpful. In her case, she was spared an immunosuppressant that potentially would have had significant consequences for her ability to battle opportunistic and rare infections. I'm going to tell you about another patient, a 70-year-old with vertigo since her 40s. She had balance difficulties for 4 years and was diagnosed with a condition known as multiple system atrophy, which she was devastated about. This is a progressive, degenerative, life-threatening, life-limiting disorder with survival often only about 7 years from the diagnosis. So she turned out to have a diagnosis of canvas. So what we've increasingly come to recognize is that there are more common later onset forms of ataxia, and Bill Nye just mentioned SCA27B, which was also diagnosed, which was only identified a year ago, but several years ago, this is another condition that was identified known as cerebellar ataxia neuropathy vestibular areflexia syndrome, more easily said as canvas, due to mutations in RFC1. So this was, although it's not reassurance to get a genetic diagnosis, it's nevertheless important to know that the natural history of some of these conditions is quite different than the fatal diagnosis of multiple system atrophy. And therefore, it was as if a weight was lifted off her shoulders because there was at least data suggesting that this is not going to be the more rapid course that she thought she would have. So I think the other importance of getting a diagnosis is to really know what to do with that diagnosis. This was a 26-year-old woman with ataxia that I saw, whose brother also had early onset ataxia with vision loss. Her parents in their 50s were asymptomatic. And she was diagnosed with a rare recessive form of ataxia that can cause ovarian failure. Knowing this really helped her plan for her family. So she was able to have a healthy, beautiful child because this was a recessive ataxia, meaning there are 2 copies of the gene that cause symptoms, and even without kind of going through the in vitro fertilization route, we knew that she would only have 1 mutation that could be passed on because her partner did not have this rare recessive allele, and the family was incredibly happy about having a diagnosis that actually made a difference to how they planned their family. So I think it's important to recognize that there are treatments for ataxia, and I think this is the most important reason to see someone in an ataxia clinic, which is that there are immune etiologies which are potentially reversible, including some where the symptoms can essentially resolve with treatment. Early treatment is important for the reversal of these deficits. And I'm going to kind of tell you a little bit about another patient, a 26-year-old with progressive ataxia since his teens. He was wheelchair-bound, and he was diagnosed with Friedreich ataxia. And this is an era of great excitement in ataxia treatment and care. As you are all probably well aware, Skyclarys is the first approved treatment for ataxia, and I think it's a harbinger of things to come. I'm very hopeful and excited with the interest from researchers as well as pharma that we'll have actionable treatment that can really make a difference in the lives of individuals with ataxia, including non-genetic forms of ataxia. So I illustrate his case because his symptoms started when he was 12, and yet he was not identified and recognized to have Friedreich ataxia until he was seen in the clinic, which is, I think, an important shortcoming and a need for us to get the message out as to treatable forms of ataxia and the approach to getting a genetic or other diagnosis. We've always, I think it's important to also not minimize the supportive treatment, including intensive physical therapy and balance training. We know that individuals who have a consistent exercise plan can not merely maintain symptoms, but improve symptoms and their decline, as long as they maintain that this balance-focused training, is not even to where they were before they started the training. So I think this is an important aspect of ataxia under individuals' control that should not be overlooked. And I think a lot of the disappointment with physical therapy, so I have patients tell me all the time, I've tried physical therapy multiple times and it was not helpful. And that's because finding the appropriate expertise for physical therapy is as important as finding a provider who understands your ataxia, as a physician who understands your symptoms for ataxia. This physical therapy can improve symptoms. Independence for ambulation, including appropriate devices, I think is critical in individuals with ataxia. There are other supportive treatments, including medications used off-label, which I'm not going to talk much about, but I think there are specific treatments that can be individualized to specific inherited forms of ataxia that may be supportive, that have strong biological rationale. I think research, I'm very excited about. This is an era of excitement for multiple clinical studies that are in various stages of development for a number of ataxias, including the most common inherited ataxias, SCAs 1, 2, 3, and 7. There's a lot of interest in novel gene-specific treatment strategies, which is really exciting. And I want to kind of summarize by kind of walking you through what the Ataxia Foundation's developed to qualify for these Ataxia Centers of Excellence. And I think this designation is important for you to potentially identify providers who really have partnered with the Ataxia Foundation to try and provide care that makes a meaningful difference for individuals with ataxia and families. This is a designation to recognize centers that provide comprehensive care for individuals and families with ataxia. I think the most important aspect of an Ataxia Center of Excellence is the coordinated clinical care team to provide comprehensive multidisciplinary ataxia care. Even if, and as we have new treatment options, we know that this management of ataxia is not going to be as simple as you have a pill and you have restoration to normalcy. I think it's going to be an ongoing partnership with various different aspects, including ways to improve function. The centers of excellence these are I think the things that you should expect from going to an ataxia center of excellence, which is genetic counseling and testing, evaluation by other specialties as needed, including things like urology, cardiology, and you may wonder, what has this got to do with ataxia? As you probably know, Friedreich ataxia has cardiomyopathy, cardiac involvement, as an inherent part of that ataxia. Although that's a unique form of ataxia, it's important to recognize that because the cause of death in Friedreich ataxia is cardiac arrhythmia, and that needs to be addressed. Ophthalmology, many of you have often experienced double vision, loss of visual acuity because of nystagmus, so treatment of those symptoms can be helpful. We know that things like depression are underdiagnosed and not recognized. And we know from the natural history studies in individuals with ataxia that up to 20% or 30% of individuals can have depression as a part of the ataxia, not as a result of the motor impairment, and that should be treated. It's important to recognize in genetic forms of ataxia what the implications are for planning for a family and for reproductive health. And really importantly, trained specialists, physical, occupational therapy, speech and language pathology to really help with function, and social services. Ask about research. So in planning for a visit, I think it's important to recognize that an Ataxia Center of Excellence recognizes that our treatment options for ataxia are inadequate, and the only way we can make progress is by engagement of individuals with ataxia, but also physicians with research, and designated a clinical coordinator for ataxia. Active engagement in ataxia clinical trials is, I think, an important aspect of an Ataxia Center of Excellence. So the NAF has a new resource, and I saw little printouts as well at the NAF table about being newly diagnosed, what ataxia is, and this is the QR code for that. I'm going to switch back to that QR code so that you can, if you want to take a picture, but I want to acknowledge individuals that I've worked with initially at the University of Michigan and now at UT Southwestern Medical Center in Dallas, neurologists, but importantly, speech pathologists, social work, physical therapy. So Liz Shar and Eitan Daniel. Eitan Daniel actually moved to Florida, so if you're in the area and you want to look him up, and at UT Southwestern, Agla Richard, Janine Vincent, and Stacy Sharon, who really are invested in identifying what works for an individual and to tailor an individual treatment plan to help support function. Thank you. So I wanted to leave sufficient time for questions as well. So I'd really appreciate questions from the audience regarding.
Anyone with a question want to raise a hand?
Come up. Oh, I'm coming. Front row seat. Here you go, Sally.
Hello. I'm a parent of someone with ataxia that we're still trying to figure out, and it's unknown, and we're going through more detailed genetic testing, but so far she's tested negative. And I'm just wondering if you know anyone in South Florida, because we've gone to many neurologists and feel like we're not getting anywhere. Like it's the same test, the same generic, and there's no personalized care.
Yeah. So I think I know that there are two designated ataxia centers of excellence in Florida. One's the University of Florida in Gainesville, and the other is the University of South Florida in Tampa. And both the neurologists at these two sites are very experienced in both genetic testing as well as clinical trials, management of ataxia. Dr. Z at USF and Dr. Subramoni in the University of Florida in Gainesville.
Okay, I got a question right here.
Hi, I just wanted to know about the Centers of Excellence and how do they earn that right of Center of Excellence for ataxia?
So it's an application process, and centers that want to be recognized as a center of excellence can apply with deadlines, I think, several times a year, really detailing what they have to offer and whether it meets kind of the core kind of resources that are available that the NAF lists. And the Research Advisory Board of the Ataxia Foundation reviews the applications from different centers to ensure that they meet the standards. And because we want to make sure that you are actually getting something out of going to an ataxia center of excellence, because there's not very many of them, and often individuals have to travel pretty long distances in order to go there. So I think and also in some ways, someone who applies to be an ataxia center of excellence really feels strongly about treating and providing care for individuals with ataxia that makes a difference and is meaningful to them.
Thank you for your talk. Nanette Presswell, GP from Melbourne. I just wondered if there are any strategies to improve knowledge in general in the neurology and medical and health professional community.
Yeah, no, it's a great question, and I think this is even more relevant really because of treatment options that are really tailored towards specific genetic forms of ataxia, and if not recognized early, we know that delayed treatment really impacts the progression. So I think this has to be a community effort. The Ataxia Foundation has the Ataxia Clinical Training Program, at least in the United States, to invite movement disorders fellows who typically see a variety of different movement disorders, which is often how ataxia presents, to try and improve education, improve recognition, how to test using appropriate genetic testing, and to identify potentially treatable causes for ataxia. But I think there's a lot more that we need to do. And I think individual patient efforts to really educate their communities about ataxia and the existence of ataxia, I think is paramount. In some ways, I think the identification of these later onset forms of ataxia, including SCA27B, that were often attributed to just aging, will improve this recognition of that ataxia affects a lot more people than the childhood onset, the young ataxias, which is still the mindset of a lot of physicians, that ataxia is, at least genetic forms of ataxia are almost childhood onset. So I think there's a lot of progress we've made, but I think it's important for all of you to be the spokesperson for ataxia.
Okay, got another question here.
Hi. My daughter has acquired ataxia from a brain tumor, and so we don't have a genetic issue going on. And basically, she was just diagnosed with having ataxia, and that's pretty much it. I don't know if there's more we should look into and that we can do to help her and support her. I mean, we do physical therapy, but with insurance, you only get so many visits every year, and so it's not like all the time. There is another organization in our city where she does do some physical activity once a week, but it's it's not a lot. So I just wondered, is there more we should be trying to do, or we can do to help her and support her?
Yeah, so I follow a number of patients actually with acquired structural ataxias. And I think one of the misconceptions is that the ataxia is entirely because of the resection itself. I at least follow several individuals where the consequence of the resection was maladaptive compensatory changes that actually worsened tremor and produced what's called palatal myoclonus. And those can be treated with, and so I think it's important, and some individuals with hypoxia, global anoxia, for example, who have cerebellar injury, can also be helped with symptomatic agents, including for tremor. So I think it's irrespective of the underlying cause. I think seeing someone with expertise in ataxia who knows pathways and recognizes symptoms that may be addressed is nevertheless of utility. Lori, we have a question here.
okay. Beth Robinson from North Carolina. We're trying now to navigate between having a good neurologist that is supportive and is helping us get through the pathways, but we really would like to go to a second consult to an ataxia place that's recognized. How's the best way to negotiate that?
So I think most providers who recognize that they may not have the expertise that provides the optimal care are willing and wanting to refer patients to an Ataxia Center of Excellence. So I have not had any provider in the community for patients that I have seen who have said, no, it's important, you need to stay here because this is all we can do. So I think initiating that conversation, I think, is key because most providers recognize that many providers are still not yet aware that there are these Ataxia Centers of Excellence. So I think initiating that conversation with them and also educating them in some ways of the existence of this initiative, I think, is important.
I don't think it's a matter of her not wanting us to go. She's been really good. She's been in contact with the foundation, all those good things. But are some of these ataxia centers willing to see you almost like a one-off where they'll say, okay, now go back to where you were and we can have that communication between
Absolutely. In fact, it's, I think, not feasible for, given the fairly limited geographic spread of the Ataxia Centers of Excellence, for, nevertheless, I mean, even if it's, and I think that's really the key. I mean, partnering with local neurologists and actually local providers for physical therapy as well. So we have an initiative at UT Southwestern where we have a physical therapist in the clinic often who will do an assessment with me in the clinic, but recognizing that they will not be able to see the patient back because of distance and ability to come back frequently enough for the physical therapy to make sense, but are willing to collaborate with local providers, including physical therapy, to really educate on what kinds of exercise plans, physical therapy plans make the most sense for that patient, including identification of more sophisticated devices to help maintain ambulation.
Okay, I got a question from Tammy here.
My husband was diagnosed about 5 years. We do see Dr. Z at USF, and the medications that have been prescribed have made his symptoms worse. He's been on three different of the medications that they usually use. I've noticed in the last year his short-term memory is almost gone. He has no remembrance of conversations and things like that. As far as medications, what is being developed, and is there something that can slow the progression of these problems?
Yeah, at this point, the only approved medication is for Friedreich ataxia, which is omaveloxolone or Skyclarys. Skyclarys, based on the clinical data we have, does seem to attenuate the decline in individuals with Friedreich ataxia. Unfortunately, we don't have any approved agents that attenuate decline at this point, but I think it is important to recognize that things like physical therapy and maintaining a balanced, focused exercise plan likely does attenuate the course of decline. And I think that does need to be used while we work on identifying disease-modifying treatment. And I think encouragingly, there is an ongoing phase 2 clinical trial, mostly in European sites, with gene suppression for SCA1 and SCA3. And there are others at various different stages in the pipeline for gene-specific treatment. So I think in the next few years, I would hazard, even in the next 5 years, I think there will be an increasing number of clinical trials specifically focused towards gene targeting strategies that would that are intended to slow or attenuate the decline.
All right, I think that's all we have time for questions. Thank you so much, Dr. Shakkottai.
Thank you all.